Good afternoon, everyone. My name is Dr. Samer Obeidat. I'm a urology consultant at King's College Hospital, London, Dubai. Thank you all for joining us today. As we all know, November is widely recognized as Movember, the month where we celebrate and champion men's health and everything related to that. So one of the important topics and one of the mysterious ones is what's related to prostate cancer. So in this short talk, I've tried to highlight some of the points related to prostate cancer, some of the misconceptions, and also we're going to speak about the incidence, mortality, how do we diagnose prostate cancer, and all things related. I hope everyone enjoys this talk, and I'll be more than happy to take all your questions and feedback at the end, and we'll try to answer them as a group, or if there is any specific questions, then I'll answer them individually. So if we start with the incidence and mortality of prostate cancer, in the UK, usually there's around 40 to 45,000 new cases diagnosed each year. This puts prostate cancer as one of the top 4 common cancers. But the interesting bit is the deaths related to prostate cancer is only around 10,000. And the lifetime risk of prostate cancer is less than 3.5%. So in years lost to cancer, it only ranks 13 compared to being ranked at 4 in the most common cancers. Why is that? We came to understand that there's probably 2 types of prostate cancer, and we will dwell about them a little bit later in the talk. But there is the common one, which is due to genetic mutation usually, and this tends to affect the elder gentleman. Or even if it starts at early age, it doesn't seem to cause much problem in the life of the man. So there's quite a famous saying. It says most men will die with prostate cancer rather than because of prostate cancer. And we can see that in the incidence of prostate cancer in the elderly men. So it's about 80% in those who are in their 80s or 90s. This is a map showing us 2 things: the incidence, which is on the top left-hand corner, and the mortality in the right lower corner. Looking at the top left one, we can see that the incidence is higher in the developed countries. So North America, Europe, and Australia, the incidence seems to be quite higher, but that is mostly because of the increased surveillance, increased awareness. Looking at the other map, which is the one on the right side, we can see that the mortality of prostate cancer is higher in the South America and in Africa. And this is mostly due to the late diagnosis. So therefore, the stage of the cancer is higher. Therefore, the treatment is not curative, it's more palliative. And we will discuss this later on. When we talk specifically about the Gulf area, there is some unique factors and characteristics that are specific to this area. One of which is the reliability and the easy access to the healthcare system. Our hospital being one of the best facilities available in the region, where we provide up-to-date evidence in what's related to diagnosis and treatment. The other thing which is quite specific here is the nature of the population. We're mostly made of young professionals, okay? And this is mostly a disease that affects those in the later stages of life. Therefore, the incidence here is much lower. There might be other protective factors like the Mediterranean diet or some hormonal factors. And also there's a very, very important factor, which is, we're considered as a health tourism country. So we have a lot of cases that are diagnosed somewhere else and they come here for treatment. But at the same time, this country is, has a high percentage of expats. And there seem to be a big proportion of them where, unfortunately, if there is a bad diagnosis, they tend to go back to their home countries to be with their family or for other reasons when it comes to treatment. And because of all these factors put together, unfortunately, the most common treatment here is hormonal treatment and therefore palliative treatment. So treatment not intended to cure the disease. And that means that most of the cases diagnosed tend to be in the higher stages or the more advanced cancer. But this does not mean per se that the incidence is higher. No, it means just that because of the more unique population, more unique health system, so this has affected what the actual group of cancer patients comes up. One of the most important factors that we came across is the age of the patient. So as we get older, the incidence and the mortality of prostate cancer goes higher. It starts to increase at around the age of 50, and it peaks at around the age of 75. This does not mean that at the age of 80 or 85 it reduces. No, it just means the way that we look at the patient and the way we survey them is different. Because once you're over the age of 79 and 75, the indication for doing routine surveillance type PSA and digital rectal examination changes, and you should have a life expectancy of around 10 to 15 years for this to apply to you. Otherwise, it will be diagnosis related to specific presentations that the patient come with. And this is quite important to distinguish from. So there's something called surveillance, and this is what we advocate for the younger men, the men without any symptoms, versus specific diagnosis to the elder gentlemen or the gentlemen presenting with specific urinary complaint. A very, very important discovery which changed how we discover prostate cancer and the incidence of prostate cancer was the introduction of a blood test called the PSA, which is short for prostate-specific antigen. This was introduced around the 1987, and all of a sudden, within a year or two of introduction, the incidence of prostate cancer peaked tremendously, almost more than doubled. And this is because of the use of this test. But what's important about it, and we will elaborate on it further down the line, is that this is prostate specific. It is not prostate cancer specific. And therefore, the test result can go up in a variety of conditions related to the prostate, like the benign enlargement, like infections of the prostate, urine infection, trauma, etc. But of course, the introduction of PSA has helped to pick up many more cases of prostate cancer and cases that were picked up at a much earlier stage of the disease process and would have been missed if it wasn't for this test. And this has reflected on the reduction of the cancer mortality. So between the years of 1990 up to the year 2010, there was a reduction of more than 20% in the cancer mortality related to prostate cancer. As I mentioned at the beginning of the talk, there is two distinct groups of prostate cancer. There's the sporadic, the common type of prostate cancer, and this tends to happen due to a genetic mutation in the prostate. And this seems to affect more than 90 or 95% of the patient. And usually the incidence of this one goes up as the patient grows in age. There's the more aggressive, but thankfully less prevalent form of the disease, which comes related to familial problems, of family having a positive family history of prostate cancer in specific, but sometimes also can be related to breast cancer. So families that have a high tendency of breast cancer or that are positive for BRCA gene, they have a slightly increased risk of developing prostate cancer. This risk is 2 to 3-fold if you have a first-degree relative of prostate cancer, and it goes up to 4-fold if there was an early onset of prostate cancer in that individual. And families with strong family history of BRCA gene, they have up to 5-fold increase in the risk of prostate cancer. I've put in this slide just an anatomical cross-section of the lower urinary tract in men, just to demystify some of the concepts related to the function of the urinary system and how it looks like. So if you can see my mouse on the screen here, if we see at the top of the picture, there's the 2 tubes coming into this round structure, which is the bladder. Those tubes are called the ureter, and they come from the kidney and they connect to the bottom of the urinary bladder. And this is how they are a conduit to pass the urine from the kidney to the bladder, which is the storage organ. And those are the really painful, or the really, the structure that cause a lot of pain and discomfort when a stone passes through them. So this is the bladder, and it's basically a ball-like structure or a sac that tends to decompress when it's empty and allows for a low pressure storage of urine. And when you go and void, it contracts to press the urine outside the bladder. Here it converges to what's called the bladder neck, from which the urethra forms. So the urethra is divided into 3 distinct sections. The first one is called the prostatic urethra. The prostatic urethra, as the name implies, is surrounded on the outside by the prostate, and it's this round chestnut-shaped structure, which weighs about 20 to 25 grams in a 40-year-old male. And this is the prostate is one of the few organs that continue to grow as we get older. And it's what causes the regular problems and complaints in men, mainly complaining from poor urine flow, hesitancy, dribbling, and it's because it sometimes can grow inward and cause a bit of obstruction to the tube or to the urethra. So we said the prostatic urethra forms into what's called the membranous or the bulbar urethra, and then it goes into the penile urethra, through which the external opening is. This is another cross section, but this is sideways. We can again see this is the kidney through which the tube goes into the bladder. The prostate is located here, and this is the male urethra, again with the 3 distinct areas: the penile urethra, the bulbar urethra, and the prostatic urethra. And this graph, nicely demonstrates why we do digital rectal examination in order to examine the prostate. Because as we can see, the nearest structure to the prostate is the rectal area, and it's immediately from the anal verge. So therefore, it's very easy, very reliable to examine the prostate through the digital rectal examination. So, risk factors to prostate cancer. The most important one we mentioned before is the age, and we'll come to that in a second. But the most important inheritant factor is race. So prostate cancer tends to be at its commonest in the Black race, followed by the white population, followed by Hispanics, and the least are the Asian and the Native American or Alaskan population. So most common, most prevalent is in black race, followed by whites. There is some migration study that environmental factor, showing that environmental factor play also a very important role in the risk scheme of prostate cancer. And it tends to show that within 1 or 2 generations of immigrants, they tend to adapt into the risk factor specific to the new area that they're living to. But remains the race is an important risk factor affecting the prevalence of the prostate cancer. Age is the most obvious, most straightforward kind of risk factor affecting prostate cancer. And as a rule of thumb, as we grow older, the risk increases. So it's about 30% in 40 to 50-year-olds, goes up to 60% in 60-year-olds, and up to 80 or 90% in 80 or 90-year-olds. Diet. Diet is a very common and interesting questions that patients ask about all the time. Is there anything specific that I can eat or I can avoid in order to minimize my risk of prostate cancer? The short answer is probably not. But there's been some evidence to suggest that consuming moderate quantities of cooked or processed tomato, which has a high content of lycopene, seems to be protective against developing prostate cancer, provided that this was started at an early age. Other important factors that have been examined is the calcium and the dairy products. And there was some evidence showing that there is a slight increase in the risk of contracting prostate cancer if our diet is heavily dependent on dairy protein and dairy calcium, and therefore avoidance can have a minimal protective effect. There is no relation between consuming fat or meat consumption and prostate cancer, and there is no consistent finding regarding green tea and soybeans. Alcohol and smoking, although they're bad for your health in general, they don't seem to have any relation with prostate cancer. Small relation between obesity, high BMI, reduced physical activity, and a slight increase in risk in prostate cancer. There isn't any specific medication that can affect or alter prostate cancer apart from one medicine, which we will discuss in more detail in a couple of slides. But aspirin and statins, so aspirin and cholesterol medication, they seem to have a little bit of protective effect against prostate cancer, but the protective effect with the aspirin is offset by the risk of bleeding, and statins seem to be helpful, but not in the short term, more in the longer term. Vasectomy, which is the male sterilization operation, seems to have a very slight risk of increasing prostate cancer. Very common question about urine infection and STIs, and prostatitis, whether they increase prostate cancer or not. The answer is no, there's no relation. And diabetes, interestingly, seems to lower the risk of prostate cancer. So, the most important slide, signs and symptoms of prostate cancer. The important bit to take home, or take-home message, is that the symptoms that we get, or the signs we get usually from prostate cancers, are those related to the prostate. And other disease processes like benign enlargement or prostatitis, they can share a lot of these symptoms. So the take-home message is, do not worry if you develop one of these symptoms, but it should raise enough awareness for you to understand that this is the time to seek some medical input for reassurance. Maybe some simple basic test needs to be done, and might be a very good time for the surveillance part of prostate cancer. So not necessarily if you develop these symptoms, that means you have prostate cancer. The answer is no, it doesn't. But it raises the awareness that there might be something wrong with the prostate or the bladder. So for example, sexual dysfunction, changes in the bladder habits, numbness or weakness in the leg, frequent urination, urgency, blood in the urine. Those are, general signs and symptoms. They might be related specifically to prostate cancer, especially in the more advanced stages, but it's not necessarily it is, okay? So 3 of the most common problems affecting the prostate. The middle one is the benign enlargement of the prostate. Very common condition, affects most men, and the effect of that goes higher as anyone increases in age. It just means that the prostate is growing, and it's a natural phenomenon. It can be, heightened because of familial inherited factors or specific related issues to that individual, but most of the time it's just a natural process. And unfortunately, if the prostate is growing to the inside, if it's impeding the prostatic urethra, then it will cause pressure and obstruction to the outflow from the bladder. This in turn can lead to what's called either obstructive or irritative symptoms. So the obstructive symptoms are the hesitancy to pass urine, poor flow of urine, terminal dribbling, and just taking longer to void than anyone else. Sometimes double voiding is put in that category, which means that you empty your bladder, few minutes later, you need to go again to the toilet. The irritative symptoms are more of the frequency, urgency, and waking up at night. So again, those are most common with the benign enlargement of the prostate, but you can see them with the prostatitis, which is the inflammation or infection of the prostate, and you can see them as well with the prostate cancer. And therefore, that's, highlights the importance of doing regular medical checkups and being aware of any potential problems that might arise. Just another slide to emphasize the same point. So many symptoms, many signs, anything outside the normal for you might be a wake-up call in order to seek medical input and just get the needed reassurance. So remember before in the slide where we spoke about the aspirin and the statins and their protective effect, there's been 3 major randomized control study to look at specific medications to see whether they help to prevent prostate cancer from happening. The 3 of them called SELECT, PCPT, and REDUCE study. The first one, the SELECT study, this looked specifically at selenium and vitamin D, 2 very common supplements that we find in a lot of over-the-shelf supplements from all pharmacies. As a conclusion, we should avoid taking them outside the normal recommended quantities, and as long as we're not exceeding that dose, they're fine. They do not increase our risk. They do not have a protective effect, but they might have a slightly increasing risk effect if they're not taking in the recommended doses. So we need to try to avoid taking extra of the supplements that we find on over the shelves in different pharmacies or grocery shops. The two medicines that we'll speak about is the finasteride and the dutasteride. And those are very common medicines used for treatment of the benign enlargement of the prostate. There's three pillars in the treatment of the benign enlargement. The first one is what's called the alpha blocker. Very common name is Omnec or tamsulosin, and this relaxes the prostate, therefore helps with the symptoms. The other one is Cialis, which is 5 milligram. This seems also to relax the prostate, the bladder neck, allow to reduce the symptoms that we get from the enlargement of the prostate. And the last two are what called the 5-alpha reductase inhibitor drugs. Those are specifically named finasteride and dutasteride. Both were looked at into great detail. The finasteride was found. So what it does, it shrinks the prostate. It shrinks the prostate by inhibiting the conversion of testosterone to dihydrotestosterone, which is the most important food, if we say, for the growth of the prostate. So by shrinking the prostate, it improves the urinary symptoms. But it has been found that it caused a 25% reduction in the number of prostate cancer cases when we compare the two groups. So one group was on placebo or no medicine. The other group was on finasteride. This was for 7 years. And we can see that at one point there was a 25% reduction in the number of cases diagnosed with prostate cancer in the two groups. The same thing applied to dutasteride. Similar result, shorter period of time, 23% reduction. But interestingly, the two groups, finasteride and dutasteride, when looked at further, it was found that there was a slight increase in the number of high-grade prostate cancer. So whenever we diagnose prostate cancer, we give it a grading system. The grading system is what's called the Gleason score, and it's 1 to 5 on each side, and we get the score by adding the two numbers that we get from the biopsies from both sides of the prostate. And we usually get a number between 2 to 10. Any number 2, 3, 4, and 5 is considered normal. 6, 7 is a low-grade prostate cancer. 8 is considered moderate, and 9 and 10 is a high grade. So more likely to cause problems, more likely to spread and metastasize. And it was found that those two medicines have a slightly higher incidence in this high-grade cancer. Nobody knows why that happened. Could it be the medicine has caused some mutation and increase in the high-grade cancer? Or is it because it helped to shrink the prostate and therefore that random prostate biopsy was more accurate and picked up something that would have been missed in a bigger prostate? We don't know the answer for that yet, but it's very important to counsel the patient whenever we're starting them on this medicine is that A, it affects your androgen level, testosterone level, therefore this male libido, masculinity can be affected. It might have a protective effect against prostate cancer in general, but at the same time, there's a slight increase in the risk of having a higher grade prostate cancer diagnosed. So again, counseling of the patient is always very, very important when it comes to the surveillance, when it comes to prostate cancer, when it comes to necessary diagnostic methods. So screening, how do we do that? We do that two simple tests. The blood test of the prostate, which we mentioned earlier, which is the PSA, prostate-specific antigen, and the digital rectal examination. The current recommendations suggest that it's not really needed to survey people under the age of 40 because prostate cancer is extremely low in that age group, unless it's a high-risk patient, i.e. significant positive family history of prostate cancer and or of breast cancer. And what's important is that the individual, if he says, for example, my father was diagnosed with prostate cancer at the age of 50, then we need to start surveying him 5 years earlier, so age of 45. Or if it was at 45, we need to start at 40 or younger. Same thing applies with the BRCA gene. But as a rule of thumb, recommendation is from the age of 40 onward, it's a good idea to have your PSA done once a year or once every 2 years with your doctor visit and clinical examination, which we mentioned earlier, which is the digital rectal examination and the blood test. Why is it important to do the two tests together? Because each one of them has what's called a positive predictive value. So it predicts the likelihood of having something significant. The digital examination alone has a predictive value of about 18%, whilst that of the PSA is about 25%. But when the two exams are put together, that suddenly increases your positive predictive value of up to 55 or 56%. And that's why it's really important to have both the clinical examination and the blood test of the prostate. Clinical examination is extremely easy to do, might be a little bit uncomfortable. All it takes is less than 20 seconds to do, and this is, the big stigma or the big worrying for men going to see the urologist is this test, although there is absolutely nothing to be worried or afraid of. It takes 20 seconds to do, a gloved finger into the back passage where we examine this surface of the prostate, which is what's called the peripheral zone. And so it happens in that zone that you get the majority of prostate cancer. So 75 or 80% of all lesions are located in that area. And this, together with the blood test of the prostate, significantly increases the pickup rate or the suspicion of having prostate cancer. As we mentioned before, PSA is not specific to cancer, it's specific to the prostate. And therefore, there's some factors that increase it, other factors that reduce it, okay? The finasteride, the dutasteride, the two medicines that we mentioned earlier, they decrease the PSA by about 50% over 6 months. So it's quite important when someone comes to the clinic, they have to mention if they are on this medicine, because their true PSA value is double that what is measured on the blood test. So if he comes into the clinic, we do a blood test, his PSA is 3, and he's been on the dutasteride for the last year, it actually means that his real result is 6, and therefore he has a slightly higher chance of having prostate cancer, and therefore the vigilance should be higher, or the alarm bells should sound a little bit higher for him, and we need to look into more details to see whether or not there's suspicion of prostate cancer. Other important factors, and this is something important when you go to have your blood test done, is that no ejaculation for the last 2 days. Make sure that you didn't have a recent urine infection, prostatitis, or someone who has been in acute urine retention recently should not have his PSA measured at the same time, because it will be falsely elevated. So, rule of thumb, you should not have ejaculation in the last 48 hours, no digital rectal examination prior to having your blood test done, and no recent instrumentation or prostate biopsy or urine infection in the last 6 weeks. PSA, a very interesting question about it is that and it keeps repeatedly being asked is my PSA normal? The answer is, if it's less than 4, it's likely to mean that you do not have a significant prostate cancer, especially if it remains like this for a period of time. So it's not just one snapshot, it's the trend that is more important. So at the age of 40, you have your blood test done, it's 1.5 or 2. A year or 2 later, you have it repeated again, it still hovers around the same number, and so forth after a couple of years. That means that you are extremely unlikely to have prostate cancer, or at least a significant form of prostate cancer. But even with low results of PSA, especially if combined with the abnormal digital examination, there might be a chance of prostate cancer. The lower the number, the less chance there is. The higher the number, the more chance there is. Until we reach really high figures, like for example, between 10 and 20, if that is coupled with a positive rectal exam, then your likelihood of having prostate cancer is around 70%. That goes to almost 95 if it's higher than 20. And if we reach a number of around 100 for the PSA, then it's almost 100% certain that this patient has prostate cancer. If it reaches 1,000, it's almost certainty that not only he has prostate cancer, but that he has spread or metastasis of the cancer at the same time. Very important before you do any of these tests is that the patients need to be aware of these things. There should be some counseling about why we're doing the test, what are we trying to achieve, what are the risks if we do this test. For it's not without its risks that we do a PSA for everyone. So if you're totally asymptomatic gentleman in your 50s, you decide to come in and you do your PSA, and it turns out to be 5, for example, then you are very likely to need prostate biopsy. Okay, there's complications associated with the prostate biopsy, including infection, bleeding, even sepsis, and not necessarily that this test will be positive. Even if it was positive, there's a chance you might be diagnosed with prostate cancer that you will require treatment for. But if you didn't know about it, it would not have caused you any trouble whatsoever. And therefore, that's why it's so important to have that discussion, that counseling with your doctor before any investigation is ordered, because consequences can be quite significant sometimes. And even with a positive, or a high PSA, positive rectal examination, a prostate biopsy will not necessarily pick up prostate cancer. Sometimes it does not, but that does not mean that there's no prostate cancer, okay? Because it's a random biopsy at the end of the day. We're just sampling part of the prostate. Therefore, continued surveillance, continued follow-up is extremely important. But rule of thumb, as with any other condition, as with any other cancer, early detection, early treatment will save life, will nip the problem at its beginning, at its early stages, and the outcome is almost always better than if left till the patient becomes symptomatic. So prostate biopsy, how is it done? So it's usually done in what's called the left lateral position. The patient is lying on his left side. The anesthetist will give him some medicine to sedate him so that he doesn't feel any pain or discomfort. Sometimes we even do it under general anesthesia if the patient is quite comprehensive. And we put an ultrasound probe into the back passage. This gives you live ultrasound images of the prostate. And through this probe, we pass a very fine needle that goes from the rectum into the prostate, and through this needle, we take biopsies of the prostate. We tend to take 6 on each side, so 12 cores in total. And because of this route, this explains the usual complications that might happen with prostate biopsy. The most worrisome of which is infection. So there's a risk of about 4 to 5% of getting an infection, whether that is a urine infection, prostatitis, or epididymitis, which is inflammation or infection of the tube behind the testis. And there is about 1 to 2% of getting sepsis, which is quite a serious systemic infection that requires hospitalization and IV antibiotics. So prostate biopsies is not something light to be taken. Not only that, but there's a false negative problem, okay? So patient has the test, has the biopsy. Unfortunately, he might get complication afterward, but the biopsy comes back negative, although we might later on discover that he did have prostate cancer, okay? So it is a simple test, but at the same time, should not be taken very lightly. This graph just to show like the areas of the prostate where we tend to take the biopsies from, and the most common figure is this one in the middle of the bottom figures, which shows that we took 6 from each side from the peripheral zone, which is the area where it is more prevalent to get prostate cancer within the prostate. What happens if the prostate biopsy is negative? We continue to follow up the patient. We continue to do serial PSA readings. We continue to do the digital exams. And as I'll mention in a few slides, we'll do MRI scans or CT PET scans. What if the suspicion of prostate cancer is still there? We still need to go back to prostate biopsies. We can either repeat the same biopsy again, we target different areas in the prostate, or we can do what's called transperineal biopsy. So this is a little bit more invasive, but it's more thorough, more accurate way of sampling the prostate. So we put like a metallic grid at the perineal area, and through that grid, we take biopsies that are 5 millimeters apart, starting from the top and going down, covering the whole of the prostate. Therefore, we reduce this randomness of the biopsy, and we try to do a more accurate sampling. But the risk of urine retention, bleeding is slightly higher with this form of biopsy. More recently, there's been more emphasis on what's called parametric MRI scan. So it's an MRI examination targeted at the prostate with certain contrast, and multiple pictures are taken of the prostate in different phases of this absorption of the contrast. And through examining all these different phases, we can determine if there is a suspicious area in the prostate. If that happens, then what we have as a new weapon is what's called the 3D ultrasound scan. And it's basically an ultrasound scan at which you can superimpose the pictures you received from the MRI scanner. So you superimpose that MRI picture over the live ultrasound picture that you're doing it for the patient, and you can highlight where the abnormal area in the MRI scan is, so that you can target that area more accurately, and therefore increases your yield, increases the accuracy of your biopsy, and also it will help to reduce the number of the biopsies you need. So instead of taking 12, you may end up taking just 3 or 4 biopsies, and therefore the risk of complication reduces quite dramatically. Same principle is also applied with what's called CT PET scan, and the same thing can be done. We can superimpose the MRI, CT picture with the live ultrasound scan. So this is my final slide picture, and it's a proposed futuristic electronic file of a patient. This is most likely to happen in the next few years, where each one will have his prostate mapped out, saved in a computer form as a 3D figure. And every time a patient has an MRI scan or CT scan, if any abnormal area is identified, that can be mapped out exactly on this 3D shape or figure. And every time a patient has a biopsy, the exact location of that biopsy can be inserted into the figure, whether it's positive or negative, and if there is any specific local treatment done, radiotherapy, etc., targeted to that area, then can be mapped as well. And this will facilitate exact and very precise follow-up for every patient. And hopefully we will see it introduced not too far off in the future. I'm going to end my talk at this point, and if anybody has any questions, any comments, I will be more than happy to take them now. Thank you so much, and it was a pleasure talking to all of you. So I have a few questions already. We'll go with the first one. Does this cancer spread to other areas if not treated in time? The answer is yes, especially if it is the more aggressive form of cancer. And this spread or metastasis is the reason why some patients will have mortality or morbidity because of prostate cancer. Rule of thumb, the area it's picked up, the more likelihood that we catch it at an early stage where it's still confined in the prostate, where treatment can be delivered in a curative manner. Milk dairy products increase the risk of prostate cancer. So the evidence is weak. Diets based on milk and dairy product, dairy proteins, seems to have a slightly higher risk of prostate cancer. But as the evidence is for all the medicines and supplements and food, the evidence is weak in the association with the prostate cancer. Is the test painful? So the blood test, simple blood test, just a pinprick and a blood sample, and the digital rectal examination, very simple, takes 10-20 seconds to do. It's no different to examining for rectal polyps or hemorrhoids, a little bit uncomfortable, but it's not really painful unless there is a rectal condition, like for example, a fissure or a thrombosed bile. But if it's, if there's no abnormality in the rectum, then the test is not really painful. So next question is, some cultures attribute increased sexual activity leading to prostate cancer. Please advise. The answer is, there is some evidence, although it might be a little bit weak evidence, which suggests that frequent ejaculation has a protective effect against urinary tract cancers in general. So that applies to prostate cancer, penile cancer, and I said prostate. So testicular cancer, penile cancer, and prostate cancer. So on the contrary, increased sexual activity has a protective effect. If the question is intended about the sexually transmitted infection, it will be, as I mentioned earlier, there was no relation between sexually transmitted infection, urine infection, and the risk of prostate cancer. So next question is, I'm taking 800 international units of vitamin E per day. Can the long-term use potentially affect the prostate? So the answer is, as we mentioned, for the vitamin E and the selenium, long-term use should be within the recommended daily intake of those two. But again, the evidence behind them is weak. It's a probability. Even if you exceed the daily limit, it does not mean you will get prostate cancer, but it has been shown to slightly increase the risk of that. Can we get cancer without any family history? Yes, of course. And the majority of prostate cancer is non-familial. Okay, so it's sporadic. So more than 90 or 90%, 95% of the cases are sporadic cases. So without any familial history or inheritance. It is a common cancer. There might be some cases in the family, but it's different to what's called familial inheritance. Yeah. So the familial inheritance is the cancer affecting the younger patients tend to be more aggressive, and this we usually test for some specific genetic mutation which has been inherited, and it does increase the risk of prostate cancer. But the most common form is that without any familial inheritance. But because it's quite a common cancer, then almost always there is someone in the family with a history of prostate cancer. So after what age should we do testing, and at what frequency? Once in 6 months is fine. So after the age of 40 is a recommended age to start doing the surveillance for the prostate. A 6 months frequency is probably an overkill. The current recommendation is once every 2 years, but once every year is also absolutely fine. Is chemotherapy and radiation not required as part of the treatment? So this is a totally different subject. Treatment for prostate cancer depends on the stage of the disease, okay? And it depends on other factors specific to each patient. So for example, a 90-year-old with low-grade cancer, there's something what's called watchful wait or active surveillance, in which case we don't do anything. We just observe the patient and we only intervene if there's a specific situation. In the standard case, where a younger patient, i.e. in his 50s, 60s, early 70s, is diagnosed with prostate cancer, that cancer is confined to the prostate, then the standard treatment is either by surgical removal of the prostate or radical radiotherapy, which is giving radiation to the prostate. This can be in conjunction on occasions with some specific medications or chemotherapy, but this depends on specific situations. And the last treatment, which is the hormonal treatment, as I mentioned in one of the first few slides, this is common in the later stages of the disease, where it has spread outside the prostate. So we are treating in a palliative form in order to just reduce the speed of the disease. And this is what's called the hormonal treatment. If I have genetic in the family of kidney cancer, which culture I need to do? Some kidney cancer subtypes can have familial inheritance. So we need to find out the type of the kidney cancer. But again, majority of kidney cancers they're not familial, they're sporadic, so they just erase. But part of your surveillance will be regular follow-up with ultrasound scans of the kidney, in addition to the blood test for the prostate. At what age do you suggest a person should go for a check, and can this be done at any hospital with a urologist or any special hospital for detection? So from the age of 40 onward, it's usually the age where we encourage men to attend to the urologist and see if there's any certain checks or examinations that need to be done. It can be done at any hospital or any clinic with a urologist. It doesn't have to be a cancer center, for example, and the majority of the problems that affect the men are non-oncological, so they're not cancer related. But this whole, awareness of the cancer, perception, and knowing that it's something in the back of my mind, I need to have it checked. It helps the patient to check for other things as well. It's not just going to be that visit for that specific thing. No, it's a complete full checkup. Make sure everything is going okay. If there's any specific concerns or any specific symptoms or questions, you can ask it. You can get a good resolution to it. What is the life expectancy of a patient with stage 4 prostate cancer undergoing hormonal treatment, and how can one help to improve the quality of life for the patient at this stage? So this is slightly beyond the scope of this lecture. It depends on many variables, depends on whether it remains controlled with the hormones or it's what's called hormone-escaped prostate cancer. Depends on the general and other medical conditions related to that patient, the other medications that he's on, his overall general well-being. But the good news is every couple of years there's new medicines being introduced. The life expectancy is getting higher and higher, even with late stages of prostate cancer. Has there been any study that attempted to show any correlation between the nature of work and prostate cancer? So, for example, if your work involves a lot of sitting for long periods of time. So the answer is no. The occupational health risk has been very obvious for bladder cancer, as that one is related to working with chemicals, especially in dye factories, petroleum industry, and wheel manufacturers, so rubber industry. But for prostate cancer, no. And sitting down does not really increase the chance of prostate cancer. It can increase the risk of developing hemorrhoids or piles, but not for prostate cancer. So next question is, thank you for clarifying this. It seems the 3 main dangers for men are rectal, pancreatic, and prostate cancer. How often should a man around 50 check for these? And is there any way a package to test for all 3? Unfortunately, there isn't, one package to test for all 3 because this involves different specialties. But yes, you're correct. And this in addition to lung cancer as well. There's simple test from the age 50 onward, once a year. I think everyone should dedicate one day for a few checkups at different specialties, make sure everything is good. I know, for example, that for colonoscopy, for rectal cancer, the checkup is once every 5 years. And even nowadays, they can send you the kit. You can do it at home to look for occult blood in the stool, and you send it back. So again, this should be individualized according to your risks for each specific type, but once every year or 2 should be the aim. I would like to ask, what are the best prevention which I can advise my relative and friends in my country and which are less likely to see a specialist due to financial issues? So again, the only strong evidence is that for lycopene, which is found in processed and cooked tomato, should be part of the diet from an early age. But apart from that, unfortunately, there isn't anything specific that someone can do or avoid to reduce his risk significantly. Can sporadic cancer later passed on to the next generation? The answer is no. This just happens due to a mutation, and it's not passed on in that way now. In case of prostate removal, what are the effects on man different functionality and what happens due to removal? So there's a few issues that affect men following radical prostatic surgery or radical prostate removal of the prostate. The most important one is incontinence, because the sphincter is quite close to the end of the prostate. So on occasions, there might be some injury to the sphincter, and that leads to incontinence of urine. The other thing is that the nerve supply to the penis runs just over the prostate. Nowadays, there's a specific type of operation called nerve sparing surgery. This can be done on both sides of the prostate to try to reduce the chance of injury to the nerves, but it should not compromise this being a cancer treatment. Okay, so therefore, if there is cancer on that side, the nerves should be taken away with the specimen, and therefore that can lead to increase in the risk of developing impotence. Apart from that, there's the immediate risk of surgery, which is the risk of bleeding, infection, injury to the bowel, to the pelvic organs. But in the right hands, those are quite minimum. Nowadays, it's more, everyone is going towards robot prostatectomy, which is the trend and the gold standard now. It gives a much better control for the surgeon, much better picture, and therefore the risks and complications are much lower. And I think with these questions, we will conclude our session for today. So thank you again for everyone who joined us today. My name is Dr. Samir Obeidat. I'm a urology consultant at King's College London, Dubai. And I will have the pleasure of meeting any one of you in person for more questions, any concerns, etc. And remember, urology is not just a specialty for men. Yes, there's a few organs that are specific to men, but at the same time, there is, the kidneys, the ureter, the bladder shared between the two sexes. So we are a specialty, we treat both men and women. There's some specific areas which are dedicated to men, the prostate being one of them, also penile problems, erectile issues, testicular problems, etc. This is all men related, and we treat a very wide spectrum of problems, of issues, and it doesn't need to be cancer. It can be anything that's affecting you or affecting your health. And with that, I will say goodbye to everyone, and thank you so much for attending today.